So we will start with the acronym, and then we'll get into some considerations that I have people evaluate as well as utilize when breaking down the questions, and then some practical tips. And then we'll go through the 10 practice questions. So we'll start at the very top of the acronym, which is safety. And those that don't know the levels, I'll get into each of them as we go on. But safety involves any consideration of abuse, neglect, harm to self, harm to others, substance use, whether that's intoxication or withdrawal, medical, or a mixture of all of them in between. Because a lot of times when you're going through these questions, there's going to be multiple levels that we have to go through and parse through and understand what in particular am I supposed to be prioritizing at this given moment. And if we don't know about a situation, it's okay to ask more information or inquire further details before jumping to conclusions or assuming anything. But we do not investigate further than getting the key details, because that's what CPS does. But that does not mean that we do not have to gather the information to get the information relayed to them. We can't just be like, oh yeah, I think it's this, and then willy-nilly about it. We have to at least have some concrete evidence that it is being done, because we don't want to assume anything in the case, but we don't want to underassume, meaning we just go negligent in what we are doing in that given moment does not matter or line up to what we're saying. So we'll get into the abuse and neglect. So abuse can be child abuse. So that is anyone from newborn to 18 years old. So anyone from 18 and under. So 17 essentially to like 0. So this can be physical, mental, emotional, sexual, or all of them all together in the particular situation. And neglect is any aspect of the basic needs being unmet. So this is shelter, they're homeless, they're not getting adequate nutrition, there's no transportation to get them to where they need to go, such as school, whether that's getting them like laundry and stuff like that. Supervision, meaning the parents aren't watching the kids at all, as well as if they don't have clothing on their body or clean clothing or access to getting clean clothing. So we'd always want to go to the child first if they are of age and want to communicate about the situation and what their view of the situation is. Because a lot of times you may get it at a school, you may get them with their parents, you may get all these different avenues of people telling us what the heck's going on with that child. We want to go to the child and figure out what's going on in the particular situation without assuming this. But if they're not of age, we're going to be observing what is going on in the situation and try to discern whether from our clinical justification that it'd be a safety issue or not. And then the adult abuse and neglect is anyone from the ages of 65 and older, or anyone has a developmental or cognitive disability. So 18 up to 65 is going to be considered like domestic violence, and that is up to them whether they want to pursue it or not. But if the person has a developmental or cognitive disability in some way, shape, or form, then age is irrelevant in that particular case, because then we need to defend them and advocate for them and advocate beyond what we normally would and on their behalf. So again, this can be like physical, mental, emotional, sexual, financial, or any of them, because oftentimes you'll see multiple factors being put into the same situation. And with financial, this means that they're not getting the money that they are supposed to be getting or they are entitled to in some way, shape, or form. Or it could be viewed as it's financial abuse because the person is acting on their behalf and purchasing things for the client in their benefit. So that is where we can't assume anything. We have to gather further information. And neglect is any aspect being unmet. Again, that's the food, shelter, transportation, connection, because people of the elder population are often not able to get connection or reach out beyond their environment, maybe due to some confines that aren't available to them, such as children. They're more connected, interwoven into like school systems and stuff like that. So I add connection there because isolation is also a form of neglecting them, because everyone needs a sense of connection and some community or entities beyond themselves to have some fulfillment. And then again, financial, not giving them the money that they could possibly need to navigate life and actually get their needs met, such as buying their food, their clothing, etc. And the key detail when it comes to the safety is once we get all of this information, what the heck do we do with it? So there are two possible aspects of if it's someone other than the person being abused, such as a teacher, friend, parent, colleague, coach, pastor, concerned citizen, or friend, etc. Fill in the blank with anyone you want to do. We need to go beyond further than just getting the information, and we need to go to the person that's being abused or neglected first before reporting, because we don't need hearsay when it comes to us reporting. Again, we don't want to have incomplete terms, and we don't want to have incomplete information when making that report. So we need to ensure that we have enough information before we proceed. So we need to have enough information to be able to relay it, since we do not want to make blank statements or assume, and we don't want to put someone in a potential situation or have their supports feel like they can't support them based on the fact that they are being told that they're neglecting them, which could be triggering to some people. So the second is if the person being abused or the person doing the abusing tells us the information, then we need to report it immediately, because we heard it from the horse's mouth and we need to get this stuff done. Because if someone tells you, hey, I'm being neglected, or I'm not getting the money that I'm entitled to, or yeah, no one's come by in about 6 days and I've been eating just pieces of bread every single day to survive, we need to do something about that, because they may not have anyone else to tell it to. And if we ignore them, they may feel like them telling people is not going to be able to go anywhere. So they just succumb to the situation. So the two situations that we possibly have with safety is if someone else tells us the information, we need to go to the person that is potentially being abused or neglected to get their perspective of what's currently going on. And if they're not of age, we can observe the situation. But if they are of age, then we need to at least ask them of their perspective and look for cues, such as if their story doesn't line up with the other person's, as well as if they keep telling us different details that aren't consistent, or if they're just kind of like standoffish and are almost indirectly telling us. And if the person that is being abused or the person doing the abusing tells us, then we have to go to that person immediately. And if the person is not of age, it's typically someone that is less than 3 years old, and we can base it off of the observation, which then moves us into the second level of safety, which is medical. And this can be physical health or physical harm done to the client. For example, if we have someone who has a broken arm in session with you, we need them to seek medical services rather than proceeding with the session and getting our services fulfilled, because their arm is literally hanging and they're not able to utilize it. Or it could be physical harm or their physical health impacting their ability to be in the office, such as let's say they are seeming faint or their shortness of breath or anything like that. Then we need to like assess them and say like, hey, maybe you should go see a doctor first before us proceeding, because you're not able to actually physically handle the session at this given moment. So for example, someone is in our office sweating, nodding out, and struggling to breathe. We would suggest that they seek medical services before proceeding, because we wouldn't want them to potentially put themselves at more harm than good based on just having them get through a session. So medical is always going to want to be ruled out if it is a consideration in the question. We can't just assume medical if it's not something that is actually there, because a lot of times the exam will throw a question and then in the answers throw in medical, and people automatically jump on and assume it and be like, yep, medical is always first. Yep, let's move on to the next question. We need to respect the exam and respect each question and navigate them accordingly. Substance use is, again, I kind of alluded to it prior, but we need to assess someone for using drugs or consuming alcohol prior to the session, or if they come into the session intoxicated or withdrawing. This will give us an idea of what their use looks like and explore the potential dangers or drawbacks of their use. Again, if someone has like medical symptoms, such as they're sweating, they're nodding out, their like hands are kind of clammy, or they're like pacing all about your office, you're of course going to assume medical first. But if medical checks out, you're going to say, hey, have you been using any substances? You haven't been able to sit down and you're fidgeting and talking 1,000 miles per minute. And then you might be like, oh, okay, you might be high on a stimulant such as cocaine. And they're like, oh, yeah, I use cocaine all the time. And it's like, okay, that's a huge consideration that we need to have and make sure, one, are you using it safely? And two, what is the impact on your current situation? So other considerations when looking at the substance use is, are they using around the children? So if they have children and they're using substances around the children, they're kind of almost indirectly neglecting their kids because they're not able to be at full attention or be able to be attentive to their children's needs. Is their use putting them or someone else in danger? So are they driving when they're intoxicated or when they're high, or are they supposed to be taking care of somebody and just not doing so? Or if every time you become intoxicated, you become angry and start wanting to harm people, then that's something that we have to kind of take note of and be like, wow, it looks like Joe's kind of intoxicated today. How about we interact with him and see how he's doing? Oh, okay. So he's kind of getting a little wild. So maybe it's intoxication and we need to de-escalate the situation before it gets any more progressive. But after that, we need to explore the impact it has on their functioning, because there are people that use substances and it does not impact their functioning. So we can't come in with our judgy selves and tell them that their substance use is bad or harming them in some way, shape, or form if there's no impact on them. And then we just have to utilize like motivational interviewing or like pros and cons of it to get them on the other side. And again, if there's intoxication within the session, we need to observe, is it putting them or someone else in danger? Again, do they drive to the session? And if we let them leave, can they potentially crash their car and kill other people? Are they able to adequately benefit from services? So if someone's nodding off or not able to focus due to substance use, we're not just going to buckle down and be like, all right, you're here, at least we can get stuff done. It's like, no, you're not able to focus, you're not retaining anything, and you're not open to discussing anything. And what is their motivation for change? We can't make people stop using substances or even discuss their substance use. So we have to just work with what they're able to lead themselves into and then go from there. Again, always come from that curious lens, always investigate what the situation is before assuming anything. But if you don't ask the questions, you don't get the answers and you don't get the insight into the situation. So keywords, and I will emphasize this, I will provide these keywords, but do not lean on them as absolutes and look for these keywords in the situation. I provide them here because it's kind of a learning basis and to allow you to almost open your eyes to like, if I see some of these, it could possibly be safety, but it's just kind of a building block of where to start. So keywords I typically tell people to keep an eye out for is develop a safety plan. If there's considerations where you would need a safety plan, inquire for more information about a situation, speak to the person being abused or the person doing the abusing, such as a child, parent, teacher, etc. Explore X, maybe the setting someone underage is in or we entirely are used to. So that way we have a baseline and then we see something off, then we would inquire more information. Again, those keywords are just provided just to have yourself in line with, but do not lean on them. And I'll emphasize speaking to the person that is being abused or the person doing the abusing first before reporting. Don't assume anything and let the situation be there. So now moving to the next level, which is the feelings level. And it's the client's subjective, and I always emphasize subjective and get the word subject because it is subject to change based on what information and what's going on in their current situation. So it's their subjective point of view of their situation and what is currently going on within their life and where they would like to go and what they want from services or to accomplish. So for example, the feelings level for this session at this given moment would be prior to me showing up and prior to you getting into the session. You're probably wondering, how in the heck does this work? Is he going to show up? What time does it start? What the heck's going on? There are multiple people telling me the information. Am I in the right session? I don't see any typing. I don't hear anything. So that was your like subjective point of view, was like all of these questions. But now that the session's going, you might have eased yourself a little bit down and you're like, okay, this is how it's supposed to go. Or maybe I said something in the safety section and you're like, oh my God, I totally don't understand that, but it's like kind of going too quick for me, stuff like that. So that is what currently is the person's view of their situation, and it's subject to change based on clarification and based on information that is provided within the situation. So it's a client or patient's, whatever one you want to say, point of view that is subject to change based on their situation or information they receive. It's the client's direct feelings, their perspective of their situation, or simply information that could be a starting point for treatment, or kind of the building blocks of what they would like to accomplish. The social worker needs to recognize where the client is and where they would like to go. And that cliche kind of statement, starting where the client is very, very important, because oftentimes a lot of people feel like they have to do actions because it's quote unquote what the client needs. But if the client doesn't say they need it, we can't just jump in with our Superman or Superwoman capes on and save them. We need to sit back and allow for the client to guide what the heck is going on. So this is where we need to engage with the client to begin developing a therapeutic relationship or rapport with the client. And we need to be aware of who the client is. A lot of times in these practice questions or even on the real exam, they will list a mom, a daughter, but the client is only the daughter, or the client's only the mom, or you're working with a family and it isolates one of them out. And we need to recognize that. Or we have originally one person. So let's say we have a woman and then her husband joins into the session. They are both now your clients because we have to recognize who they are or who is the person. So the client be one person or multiple people. So being aware of what the situation is asking will lead to you being able to get the correct answer, because your question is always going to link to the answers, and the answer you choose should always link back to the questions. So do not get too carried away. And the keywords again, and I'll provide the preface again, do not take these as the absolute and an exhaustive list. They are just building blocks and things that can get you on the right path. But when you're reading the answer responses, do not link and jump to keywords. Understand what the statement is saying prior to choosing your answer, which moves us to the next level of the acronym, which is assess. And this is the clinical or objective. And I always emphasize the word objective and take the word object out of it. So if you picture an object around your room, so let's say you have your cell phone near you, that's an object. In order for me to change what my cell phone looks like, I have to put great deals of force into it, but still the cell phone is what it is. So if I throw it at the wall super hard, it may break it in half or crack the screen, but the cell phone is still the cell phone. So the assess level is looking for the objective or unchangeable information about the client's situation and what their presenting needs are. So it can provide us more information on what the client's situation is beyond what they've already told us. So this information can be very difficult to change, such as your cell phone or the objective or object within the objective information, since it involves direct observation and evidence for what has been and what is right now. So this is the client history. This is what the client has done before. This is what not worked for the client. This is what's worked for the client. And this is the identifying information. So we may utilize screening tools, contact family members. If we have a release, don't bring confidentiality here. We're ethical. Explore the client's history. So it's the mental health, it's the treatment history, potentially medications if they've been on it, who is supporting them, what supports do they have, what's their physical health look like, do they have any substance use, do they have a legal history, etc. This is the information to give us a better picture of what is going on and how we can adequately help them. So the client's previous behavior attempts to improve their situation is also relevant. What have they tried before? So that way we're not providing them strategies they've already tried to utilize and tried to benefit from in some way, shape, or form. So this is essentially the starting point of the social worker and the client working together to develop a plan of action to address the client's identified needs or wants. So once we have their subjective point of view of what they want to accomplish, this is where we get the building blocks of how we can actually get this done. So that way we can help them work and propel further. In keywords, emphasis again, do not take it as an exhaustive list and only as a building block on how to open your eyes to at least starting to view the situation a little differently. Assess, inquire, gather, delve, explore, contact, etc., to then start getting a basis on it. So once we have our information, we have to figure out how in the heck are we going to utilize it in an effective manner. So the first way that we can do this is the refer. So this involves providing referrals to other professionals within our agency or finding other professionals outside of the agency to directly influence the client's situation and elicit change out of what they are trying to get from services. Essentially, if we do not have the experience to get the job done, we get them on the heck out of our agency. Or if we are not adequately ethically able to do it based on a dual relationship, conflict of interest, etc., we need to get them to a provider that can help them. This can also involve connecting someone to community resources and services that can supplement treatment. It doesn't mean they entirely go away. It just means that they're going to another agency for some services and then coming back. So referrals to other professionals are based on the social worker not having the appropriate experience to treat the client. They may have all of the experience besides one area, and if the client wants to talk about that one area, we need to get them out so that way we can nip it in the bud and not negatively impact the client's situation based on the fact that we want to propel the situation our own self and actually step outside of ourselves and navigate what we need. And a lot of times people say, well, this program over here, or this document over here told me never to refer. That is an absolute lie, because if that was the case, there would be only one level of social work and we'd be a jack of all trades, if you will. So if you need to refer based on us not having the experience, that is what we have to do. Do not think so black and white with this or in absolutes or hard and fast rules. There's more levels to us navigating the questions. So this is where the social worker is exploring their limitations and finding ways to supplement it. So referral to a professional within our agency would involve finding someone with the appropriate knowledge and expertise within a particular area of interest to better help the person than we can because we don't have experience. The other professional will have to have more experience than us in that particular area. We're not just going to find a conveniency factor of, okay, this person has a little bit of experience in this area, so let me get them the heck out of there. That's not what we're supposed to do, and that's not appropriate for us to possibly do it. So key emphasis is they have more experience than we do because they need to better adequately treat the client. So for example, a client needs substance use services and Phil does not have experience with treating clients with substance use disorders. However, Becca has experience with treating substance use and would better treat the client. Therefore, Phil would need to step outside of himself and refer the client to Becca for the services because he does not have the experience needed to adequately treat the person. So we need to inform the client and make an informed referral prior to just doing it. We can't just shove clients out because that's not appropriate. We need to go upon ourselves and actually get the client what they need. But again, we would tell them, hey, I understand this is the services that you're seeking. I don't really have that experience. I can do a warm handoff, which means I'm going to make the transfer, make sure you get there and provide you all the information needed to get those services. So that way we're just not leaving you on an island by yourself to navigate this system. The other continuum could be referral to a professional outside of our agency because no one at our agency is able to treat or serve the person in an appropriate manner. So if someone needs substance use services and none of us have substance use experience, we need to get them out of there. We need to follow the code of ethics and be competent in the areas and not just say we're going to be competent for the sake of gaining an experience off the benefits of clients that are vulnerable. So we need to make sure that the professional is competent and the location is available and accessible to the client of interest. Again, we can't just pull a conveniency factor and say like, all right, here's this agency over here that you may not be able to get transportation to, or you don't even like, or you've been there and had a negative experience, but it's more convenient for me. So here, have a good time. So you'd have to do your due diligence, assess the client, tell them about the referral, and then it's up to them whether they want to go there or not. And if not, we have to provide another referral. An example here, someone needs trauma treatment. Phil does not have experience with treating trauma and no one at his agency does either. Phil would need to find someone with trauma experience and make the referral to the person that can better treat the person with trauma. So we need to inform the client of the necessity of the referral and ensure the referral's appropriate for that person prior to them telling us their trauma story. We don't want to open up a can of worms that we don't intend to go fishing with. We'd keep it closed, give it to someone that likes fishing, and let them get the prize. So again, if you don't have the experience, you need to refer them to someone at your agency or someone outside of your agency based on them having more experience, as well as the client being informed and aware of what is appropriate in the situation. Other times where you'd want to refer out are when you're not able to seek supervision around it. And that is often when the client is bringing something into the therapeutic process that we can't parse out. So some of those could be the client is sexually attracted to the social worker. We can't just go to supervision and say, hey, let's say Nikki's attracted to me and has a crush on me, but I think I can buckle down and set boundaries adequately and make it happen. No, I would refer them out and give them to somebody that would not have that same relationship with the person, because someone having sexually attracted or feelings for you could negatively impact their objective view of treatment, and they may just pseudo be doing strategies just to please you and not actually benefit in their situation in some way, shape, or form. So we have to have the competency and wherewithal to look within ourselves and say, hey, I'm not able to do this based on the fact that I'm not somebody that can change somebody's mind. Someone's feelings are their own feelings, and I need to get them out of services so that way, one, I don't put myself in a dangerous situation, and two, I don't put them in a situation where they're not able to benefit themselves. Second situation is the client knows the social worker outside of the agency, such as a conflict of interest or dual relationship. So let's say I attend the same church as this person, and they see me and come up to me and want a session during church. I'm not going to be able to sustain that very long. I'm going to say, I think it's best if I just refer you out to somebody. I'm not going to end my service at this church, and I don't want you to transfer outside the church. So I'm going to refer you out because that's the most appropriate action at this given time. Or let's say you start seeing a client and you notice that your cousin's dating this person. I'm going to transfer them out. I'm not going to have them sitting at my dinner table or at a family reunion based on the fact that I want to have clients. Bad moves, bad vibes, don't risk it. And then kind of similar to the social worker is connected to the client in another way outside of the agency. Again, another like conflict of interest or dual relationship. Let's say I go into a mechanic shop. I see my client working on another car. I'm going to say, probably best to go to a different garage because I don't want to risk my client working on my car and then not going well and me blaming the client. Bad moves, bad vibes. So the social worker knows of a community resource that could benefit the client, such as a support group, food banks, housing, etc. The client will need to be in treatment with the social worker still, but they would still get supplements outside of us. Again, we would help refer them to the resource, but they would still be able to do it. And again, the keywords that you might see: refer, connect, coordinate, link, deliver, etc. Any way of us putting them from where they're working with us to somebody else based on experience or necessity, ethics-wise, or they could benefit in some way, shape, or form. Second level is educate. So this is us providing information about the services that the social worker will provide, another professional will provide, or any area of interest to the client. So back when Michigan had medical marijuana passed, a lot of clients asked, Phil, what would medical marijuana do for my situation, or what are the negative impacts of this? And then when we legalized it for recreational use, I got the same wave of questions, and I had to be geared and ready for questions around medical marijuana or just recreational marijuana in general and what it would look like in their particular situation. So again, this could be area of interest they're wanting to know about, or what about you're starting to provide to them. So you may have a situation where it's like clients never been in services before, or they're in couples and they're not on the same page. Providing them information about the situation of what they're currently going through could better equip and help them in the situation and actually empower them to get closer to their goals. So the goal of this level is to ensure that the client is aware of what to expect, and so they can provide informed consent. They're informed about what their situation looks like, so they consent to treatment. So the client is able to know what to expect and what is actually available and possible in their situation as well. It allows for the client to have knowledge and competency around their own services and treatment, and just better equips them to be their own advocates in their situation. So it allows for the client to be able to adequately know what to expect while in treatment, or to better inform them on their ability to make sound decisions for themselves, because power is knowledge and knowledge is power, and to become more aware of particular topics of interest, marijuana use of their medications, anger management techniques. If they're struggling with anger, you provide them anger management techniques. They're able to better escalate their own stuff, positive strategies for anxiety, mindfulness techniques, etc. Anything you could possibly think of. And me doing this right now, it's kind of an educate level, because I'm providing information to better equip you guys to take the exam and walk in there and kick it in the chest. Again, I am providing information to better equip you guys. So that would be the level. So now walking into the absolute trickiest levels of the actual acronym. Most people have questions for what the heck is advocate, what the heck is facilitate, and what in the heck does intervene look like? Well, sit back and let's get down to business. Advocate is when the social worker gathers the needed information, resources, and services for the client to deliver it to themselves. So an advocate, think of an advocacy rally, a whole bunch of us advocating for a purpose, but not all of us are going to benefit from this. So advocate is where the person determines whether they will utilize or benefit from the information, from the services, or the resources we give them. So a lot of you guys, if you do client face-to-face work, you'll gather all of these awesome resources up for the client, get them ready to utilize them, and then they don't utilize them. That was you advocating on behalf of the client. You got them all the stuff that they needed to get into that Section 8 housing, and then they didn't follow through. So the person determines whether they utilize and benefit from the services, but it's still our duty to gather it up and allow for them to do it. The best way to view this is advocate happens outside of the agency. Educate and all the other levels happen inside of it, besides like facilitate. But I'll get to that one in a little bit. So it allows for the person to have control and reinforcement throughout their treatment or around their efforts or their work that they're putting forth. So it's gathering together for a cause, but it is up to the person to exercise their right. Again, when you think of advocacy, think of a huge rally outside for a particular cause, aka we're advocating for the client. So we're getting them all the stuff that they need, and then it's up to them to actually do that service or utilize the resources, etc. So the client will be the main factor in whether they progress, regress, or stay in the same area. So a couple of examples to drive this home. Phil has problems with time management and would like to be better able to improve it. The social worker provides him with a planner that he can utilize outside the agency. It is up to Phil to fill out and utilize the schedule to improve his time management skills. It's not up to the social worker to say, hey, Phil, did you get that planner done? Or are you utilizing the planner like you said you wanted to? It is up to me to get it done. So it's not for the client and me to do, it's for the client to do. I gathered the resources, aka the planner, and it was up for me to do it. Another example, Phil is doing a study group on the acronym and walking through practice questions with social workers who are preparing to pass their ASWB exam. Phil provides them with the information for the acronym and leaves it up to the participants to utilize it or not. The participants have the information regarding the acronym, and it is up to them whether they utilize or benefit from it. So some of y'all just wanted to come for the questions. Some of y'all came for the acronym and try to understand a little better. Some of you already know it and just want to sharpen your blades. But at the given time, it's up for you guys to walk into the exam and utilize it to the best possible ability that you can. And that's the thing, is advocate. Think of us doing an advocacy rally, and it's up to the people that we're advocating for the rights for to benefit from it in some way, shape, or form. And another example, Rebecca has been struggling with balancing studying for the social work licensure exam and handling her anxiety while answering practice questions. Phil provides Rebecca information on how to break down the questions, combat her anxiety, and remain focused while preparing. It is not up to her whether she uses it's up to her. It is up to her whether she uses the information or not. So Again, Phil provides the information and tips and strategies, and it's up to Rebecca to get the job done. It's not up to Phil to work with her in the exam, but that is what it would look like. Facilitate, on the other hand, think of facilitate, someone's gathering a whole bunch of things together, and it's up to someone else to deliver whatever else is going on. So when someone facilitates an exchange, they've made that connection, but it's up to the two people to get the job done. So this is when the social worker gathers the needed information, resources, and services for the client, and another professional delivers the service to and for the client. So facilitate, the social worker facilitated that connection, and it's up to another professional to make sure that client gets the job done. So someone is influencing the likelihood that someone will benefit from the services and or the client's needs are being met. So there's some follow-up and some accountability that exists within that situation now. So the act of someone assisting a client with getting their needed result results from services. So the professional serves as a sense of accountability and some type of connection to make the likelihood that they benefit from what they're doing in some way, shape, or form more likely. So someone helps connect you with someone to get further along in the process. So let's say somebody told you about me and my study groups, and then you joined, they facilitated that connection. And it's up to me to now help you increase the likelihood that you pass your exam in the long run. But that is what facilitate looks like. Someone else saw that you had a need, they connected you with me, and now I'm here to help you. So a couple more examples. Phil gets a list of anger management techniques from his therapist to try at home, and Darlene is contacting him daily to inquire about the utilizations of the techniques provided. So Phil wants something, a therapist gives him the strategies, and another professional, Darlene, is following up with Phil now. So again, that sense of accountability, because if somebody's asking you, are you utilizing your techniques almost every single day? The likelihood of you utilizing those techniques astronomically goes up. Another example, Phil is working with a client who struggles with depression and who recently lost his housing. Phil connects the client with a housing specialist at his agency to ensure that his client gets his needs met. The client would still work with Phil, but they're getting additional assistance in an area that he lacks. So Phil is working with the client, and he connected with another professional to get his needs met, aka the housing. So this level is kind of like utilizing case management services. A therapist would oversee it. Case management fills in when needed, or benefit specialist, etc. Whichever you want to tag on. And the key emphasis here is it's going to be tried at home, as well as connects the client with someone else. Again, connecting them and facilitating that connection with and for them. Another example, Barb has been working to pass her ASWB exam and has not been successful. She has a friend, Jody, who has been watching this guy on YouTube. Barb reaches out to this guy on YouTube, Phil, to increase the likelihood she will pass her exam. Barb has been trying to pass the exam on her own, and Jody connected her to another person to impact her situation. So connected to another person, you're facilitating that connection. The act of Phil following up and providing guidance will increase the likelihood and comprehension of passing the exam. Again, increasing the likelihood of whatever the person's goal is with and for them. And then intervene is the option that everybody loves. Everybody loves this one based on the easy fact of it. So intervene is when the social worker will gather information, resources, and services for the client. And they, the social worker, will come in with their shiny cape and help the person and get the services and help them fulfill the needs that they see fit. So this is whenever the social worker does an action to help promote their situation in some way, shape, or form. So when the social worker helps to develop or deliver plans for or with the client, they will work with the client to ensure they're getting closer to their goals. So this is where the social worker kind of comes in and does what they feel is necessary and best with and for the client. So this is any action that you see the social worker doing to progress the situation in some way, shape, or form. Couple of examples to drive this one home. Phil wants to better handle his anger. So the social worker he's working with provides him a list of anger management techniques that they identified together. So they identified them together and they provide him a list. The social worker will follow up with Phil to ensure the positive strategies are improving it. Social worker will follow up, meaning the social worker does an action on their own to increase the likelihood of this happening. So the social worker worked with Phil to identify positive strategies, and they are following up with him to ensure that his anger is addressed. Again, they are doing it, no one else. Another example, Rebecca has been feeling more depressed since her brother moved away, and she meets with a therapist to discuss it. The therapist works with Rebecca to identify positive strategies to improve her depression symptoms. So, rather than providing a list of connecting her with another professional, the social worker assisted her by themselves. Again, they are doing the action. So the social worker works and identify. So they are doing the action with and for the situation. Another example, Jackie has been struggling with understanding how to break down questions and stay motivated to study for her ASWB exam. She reaches out to a guy named Phil for assistance. Phil connects with her, works with her on how to break down questions and to remain motivated throughout the process. Phil directly interacted with Jackie, and he is also trying to impact the situation directly. So it's not someone else. It's not anything else out of the norm. It is the person themselves. So anytime the social worker does an action, it is an intervene. That is the best thing to remember. And I'll do a quick review and then drop some ditties of how to do it. So the acronym starts with the client and starts to move towards the social worker. So safety, it is focused on the well-being of the client and the potential harm to them or someone else. Feelings, it is all focused on the client's view and the needs of their own situation. Assess, it is focused on the client's history and their situation. So again, kind of starting to trickle a little further. And then refer, it is focused on the client's needs and directing them in the best possible way to get them met. Educate is focused on increasing the client's competence and their knowledge of the situation, but the social worker is starting to get a little more involved in providing it. Advocate, and is focused on allowing the client to take control of their situation and to promote change. And the easy way to remember the advocate and what it means is A equals all by themselves. So advocate is when you give them all the stuff and they do it by themselves. Facilitate, it is focused on the client working through their struggles to make progress and connecting them to another professional. Again, it's kind of close to the social worker, but not as close as it could be. And an easy way to remember the F, so the F in facilitate, F equals friends, because another person does it. So somebody that you know has now started to work with them. So facilitate, F, friends, another person is doing it. A, advocate, they're doing it all by themselves. And then intervene, it is focused on the social worker working with the client. Again, the social worker is now promoting action and working with the client. So if you've noticed, as we've gone down the list, it's kind of gone all about the client, client does it by themselves. When that doesn't work, we connect them to somebody. And then afterwards, we come in and try to swoop it to get their needs met. We are the last resort. And an easy way to remember this, the I in intervene equals I do the action. So, quick review of the last ones that are kind of tricky for most people. A, all by themselves. F, friends because another person does it. I in intervene is I do the action. So an easy way to recall the acronym: savvy farmer Aladdin raises expensive apples from India. Savvy, safety, farmer, feelings, Aladdin, assess, raises, refer, expensive, educate, apples, advocate, from, facilitate, India, intervene. And the acronym is only for application questions only. Do not apply to every single question, because it's going to confuse the heck out of you. And you're going to say the acronym is not effective and it's not going to help me in some way, shape, or form. So do not apply them to all the questions, because if so, you're going to be very let down. And if the exam was that easy, Phil would be living on a mountain somewhere doing just erratic things, because I'd be a bajillionaire, because the strategy would work that effective. So you may be wondering, what are the types of questions? So let me peel this back. So recall, or any questions we have identify specific social work terms, theories, concepts, etc. These tend to be the ones that everyone wants the exam to be about, because they're easy and regurgitating information. So they're kind of our one-worded answers or one-worded responses. So for example, like Freudian theory, like what is the first stage of psychosexual development? The medications. Somebody that's diagnosed with generalized anxiety disorder, what is the most likely medication? Diagnosis, here's a bunch of criteria. Which diagnosis best fits this? Or like Koberg's, etc. This is the content-based questions everyone loves. It's because that is what most programs are based on. And they try telling you, here's all this nice information. People are stressed the heck to their gills on how to remember the information, and then they lose their minds. But when they walk into the exam, they get a haymaker from Tyson, because the application and reasoning questions are the ones that dominate and destroy and make up the majority of the exam. So the application questions are where we need to apply. So go figure, application, what does it mean? To apply specific social work terms, concepts, theories, and all of those things to particular client situations and clinical aspects that we have to navigate through. So these tend to be client write-ups and ask for the social worker to respond in an appropriate manner. And if you guys have taken the practice exam or have taken the real exam, this is the majority of the exam where you get, this person's coming in, here's all of their situation. How do you best help this person? So a client presents, so for example, a client presents with depressive symptoms, anxiety symptoms, they're homeless and utilizing substances and have high blood pressure. What would you do first with this person? Well, in this situation, and if you've been rocking and buckling, the key considerations that jump out to me are the substance use, because that was a safety category, and the high blood pressure, because that's also a safety category. Depression and anxiety are going to be important, but not as important. And then the homelessness is going to be a factor, but not as prevalent as, you guessed it, the substance use, because the substance use is the absolute most contributing factor to the situation. Yes, they have high blood pressure, but what impact? We'd always want to start with the substance use and then peel back the layers. So that is what you have to keep in mind, is what is the most important thing in that given moment and what's present in the situation. And given this was a minute situation where there's no background or no fill-in information, but for the sake of the example, substance use would override all of those on the onset. And we're typically going to see first, next, best, most, and should for our application questions. And then the reasoning questions are where we need to come up with a specific solution to a problem. So these typically require us to break down an ethical situation. So all of our ethics situations are typically going to be reasoning, to address a particular problem, such as our research program evaluation and development, as well as a mixture of all of that. So administrative work and supervision, etc. So like I said, we need to come up with a solution to the problem. And we're also going to see the same words: first, next, best, most, and should, because all of those words mean the same thing. Do not let one word blow your mind and forget your social work practice skills and your knowledge and competencies, because it tends to do that. And you may be wondering, well, how in the heck do I explain them? Well, that is what we do now, because they all mean the same thing. So first essentially means what the social workers should start with in this situation. Next is saying what should the social worker start with when reacting to the situation, or the details that were already provided. So essentially, what should the social worker do first after everything that's been described? Best is what saying what should the social worker do first when responding to the situation, because best is essentially saying what is the most appropriate action. And then most is saying what is the best explanation or appropriate action when the social worker should take in the situation. What you go back to best, and it stems back to first. So all of these words mean the same thing. So don't overthink this thing, and don't let this stretch you to the gills based on one word. Do not let one word sway you all the way off the path, because if so, it's going to be a very fruitful little attempt. So now, what are the 5-step considerations that I tell people to look at when they are breaking down the questions? So first is always, who are you? Like, what type of social worker? Because this is going to dictate what we need to be doing in our particular situation. So if we're like an outpatient social worker's job is to assess, stabilize, maintain, and discharge them out, because they're more longer term. Hospital, on the other hand, is going to be more like assess, stabilize, and you're outside my door because you're not dying, you're safe, and we're giving you the resources needed. A school is going to be more or less like an assess, stabilize, monitor. You move down to the next grade, let's repeat it to assess, stabilize, monitor, repeat, etc., until they graduate or age out of the system. So knowing what type of social worker we are and what we're doing is going to better dictate what we should be looking for in the situation, what has already been done. Second is, where are we? This setting is going to tell you a whole lot of what you should be currently doing in your situation. So like in office, social workers are going to base their information all on what the clients tell us and what they're presenting with during the treatment. We don't have a whole lot of bearing of what happens outside of there because we don't have access to it. If they don't tell us, we don't know. And if we're in the community, on the other hand, we have a whole lot more burden and a lot of access, so that we have their account plus what we can observe in the community while we're meeting with them. Like, what does their home environment look like? What is their financial situation? What supports do they have? Is there any safety concerns? Again, when we're in the community, we have a whole lot more backing and a whole lot more monitoring on us. So knowing that is also going to tell us what we should be doing in the questions and navigating that as well. And then third, fourth, and fifth tend to be the most important considerations when we're looking at this. Like, who is or who are your clients? So who's providing this information, and what is it about, and what is it leading to? So the client will often be in the correct answer and allow for you to be able to connect the answer back to the question. So again, if we're working with a family and it's only describing considerations and situations about the daughter, the family's not your client. The daughter is now your client because it's all about her. The question will often tell you or be focused on the client of interest. And it's going to be a lot of back and forth, but the question is not there to trick you. It's there to help you and guide you in some way, shape, or form. 4, what is being presented in the situation? Again, you're going to have a whole lot of situations, like symptoms, situations, considerations, all brought up with all different priority levels. So we'll be showing multiple factors, and we need to know how to prioritize them, sort them, and put them to the side, break them out, rule them out, and choose the correct answer for that given client and in that given moment. Again, we don't assume anything that's not there, we don't add there. 5th, what can we do, or what does the question want us to do with the situation or symptoms that are being presented? How do we react in the situation? And what is the best possible action for us to do? Oftentimes, the last sentence is going to tell us what it's looking for, but stick with your gut and trust yourself. If you're reading a question, something jumps off the page at you, probably take note of it and say, why is this jumping out of the page? And is the question telling me this is what I should be looking for? Don't assume, sit back, respect it, and get it done. So always figure out who you are, where you're at, who is or who are your clients, what is being presented, and what do I actually need to do about it. So now moving into the additional tips that I have, read the question 3 to 4 times. And you may be saying, holy smokes, that's a lot of times. I don't have a lot of time, but they are purposeful reads. First time, understand the situation. Second time, you break it down and navigate the situation and pull out the important information. Third and fourth is to compare your answers back to the question to ensure they connect. A lot of times, people say, I'm able to rule it down to 2, but then you just sit with it and don't compare back and read the question to understand which answer actually aligns and gets better connected with it. The second one, and the biggest factor that I often see people fail the exam for, is you second guess yourself. Never, ever, ever, ever second guess yourself. This will cause your anxiety to skyrocket above the roof, which will destroy your confidence throughout the rest of the exam. When you're reading question, let's say it's 3, you aren't sure, you move on to 4, you're focused on it. By question 5, you're already thinking about question 3, and then your mind is gone, and then you just get worried and start speed going through the questions so that way you can go back to question 3. Read it, understand it, and trust yourself, which leads me into the next one. Trust yourself and base your answers and prep on what works best for you, not what worked for your friend, not what worked for somebody that tells you that they've helped people pass, not what you have heard and have had 5 different styles. Choose the style that best fits your needs, accept your limitations and strengths, and walk towards what you need. When you trust yourself, you believe in yourself, you tend to accomplish things that you otherwise did not think that you could possibly do. So please, if you can do one thing, trust yourself, believe in yourself, and actually accept that what is currently going on is what is supposed to be happening. Fourth, develop a routine or process that works best for you and allows you to lower your anxiety because you know what to expect and what could possibly be useful for you in the situation, whether that's you want to schedule breaks. Like, for example, I took a break at the halfway point, but I also was twiddling a pen because I know that I'm not able to sit still. So that was a way that I was able to combat my anxiety, help myself focus, and be able to walk to where I wanted to go, which was passing the exam. As well as when you have clarification, it allows you to become more comfortable and allows for you to sit back and relax a little bit because you know what to expect. And when you know what to expect, it's not as scary. Fifth, invest in yourself and allow yourself to have leeway when preparing. Do not expect perfection when preparing for the exam or during the exam. You're not going to know everything. You're going to have to get questions wrong. Everyone does. I didn't get 100%. You won't get 100%. No one I've ever met has gotten 100%. And if you get 100%, good for you. But everyone just needs a pass, so then you get your licensure. We are human. We will make mistakes. We will have slip-ups, and we will not be where we think we need to go. But we have to embrace what we're currently doing because that's going to lead us to where we want to go every single time. So be willing to invest in yourself, accept yourself, and be able to navigate closer to where you want to go. And do not let the little things destroy the big picture. Do not let you getting one question wrong or not knowing a particular concept get your mind blown to the fact of where you are going to lose your motivation and what you currently need in your situation. And don't let all this stuff distract you, and always have a way to reset yourself. So identify a way to reset your mind when you find it wandering. So if you find it, well, that's wandering, or into anxiety. Because a lot of times when you get into this exam, you see one thing, or you're at like question 75 and you can barely see because you're so wound up or you're so tired. Find a way to reset yourself. An easy way to do this is remember why you started and who could be losing out based on the fact that you're not focusing. And that is the thing that you have to remind yourself. Why is this important to me? And what do I have to do to keep myself fresh and going? I need to identify a way to get myself fired up on a dot of a hat. You want to be like, all right, I'm ready again. So that is what you have to keep in mind. So question 1, a medical social worker is completing a routine visit with their 75-year-old client who has been diagnosed with a terminal illness. The last couple of visits, the client appears to be getting worse. The social worker believes their client has started drinking alcohol, which is why they have gotten worse. The social worker sees empty alcohol bottles in the client's kitchen. What should the social worker do next in the situation? A, explore the reasoning behind the bottles with the client. B, refer the client to substance use treatment. C, discuss the negative impacts of alcohol on health with the client. D, gather information on the benefits that alcohol has in the client's life. When you have your answer, type the word kitchen in the chat. Opening the polls. Thirty more seconds. All right, slapping the poll shut. The majority think it is A. Second place is D. Third is B. Fourth place is C. Let's look at it. So we are a medical social worker. It is a routine appointment. So we've had some rapport with this guy, 75-year-old, and he has a terminal illness. So some medical. The last couple of visits, he appears to have gotten worse. Social worker believes their client started drinking alcohol, and that is why he has gotten worse. And the social worker sees empty bottles in the client's kitchen. So this is giving me an application question, why it's a client write-up, and it's asking us to respond to it in some way, shape, or form. It doesn't involve ethics. It doesn't involve any like recall concepts. So let's peel this bad cat back. So explore the reasoning behind the bottles with the client. Feelings, why we're going to be able to obtain his perspective of what's going on with him and for him. Refer the client to a substance use agency. Refer. Discuss the negative impacts of alcohol on health with the client. Educate. Why? Because we're going to be providing him information on the negative consequences in some way, shape, or form. Gather information on the benefits that alcohol has had in the client's life. Assess why we're gathering information about his situation and his substance use in some way, shape, or form. So, quick review: medical social worker, routine appointment. So, there's rapport. 75-year-old, he has terminal illness. He looks like he's like regressing, believes there's alcohol use, there's empty bottles in the client's kitchen. So, we're going to automatically rule out B because, yes, there is some substantiation of it, but the social worker only believes. There's no real evidence. And let's say those bottles aren't even the client's. He's just starting to pick up bottles based on the fact that he wants extra money, or maybe someone came and visited him and those were those person's alcohol bottles. We can't assume anything based on evidence that we are trying to drive a fact. So the social worker only believes but does not know. So we're not going to educate the person on the negative impacts of it. Why? Because there's no particular evidence of it. And the client would be like, why are you talking about alcohol use to me and impacting my health? I have a terminal illness, and alcohol is not even a thing that is a part of me that we know of. So we're not going to be able to explore the benefits alcohol has had because we don't know if the client's ever used alcohol or is using alcohol now. So exploring that with them is not going to be possible. So we always want to start where the client is. So we're going to explore where these bottles come from. And then we get our answers. Is it because he did it? Is it because he's collecting them? Did someone else drink them? Etc. We can't assume anything in any situation in any way, shape, or form. So that is how we would look at that question in particular. Question 2. A social worker in an outpatient clinic is meeting with a mother and her 12-year-old daughter to gather more information around the daughter's recent legal charge. The mother reports that her daughter has always been respectful, looked out for people, and succeeded in school. But recently, she has been talking back, sneaking out of the house, and stealing from others. The mother is concerned with the friends her daughter has started to hang out with. The daughter reports that her mother just needs to loosen up and that everything is fine. We were just having fun. What should the social worker consider first in this situation? A, the daughter's current developmental stage. B, history of childhood trauma and attachment issues. C, drug use and addiction. D, current abuse and neglect. And when you have your answer, type the word coffee in the chat. Opening the polls. 30 more seconds. Slapping the polls shut. So the majority think it is A, close second is C, third place is D, fourth place is B. So let's peel it back. Social worker, outpatient clinic, mother, 12-year-old daughter. In the purpose, more info, there is a legal charge. The mother reports her daughter has always been respectful, but recently sneaking out and stealing from other people. So some change in behavior. The mother is concerned with the friends her daughter started to hang out with. The daughter reports mother just needs to loosen up and everything's fine. So the daughter has an entirely different view of the situation. What should the social worker do first? And then this one is going to be more or less a recall because we have to know the information leading up to this. So, quick review: social worker, outpatient clinic, mother, 12-year-old daughter, more info on the daughter's legal charge. Daughter's been respectful, looking out for people, succeeded in school, but more recently, talking back, sneaking out, stealing from others. Mom's concerned, daughter saying, Mom, loosen up. We're just trying to have some fun. So, based on the information and the particular client, we have a 12-year-old daughter. So, knowing who a 12-year-old person is, they are often going through different changes. So, we're not going to say current abuse and neglect because mom is not reporting that and daughter's not saying that that's happening. There's not going to be a childhood history of attachment issues or trauma because it's not cited again. And the kid's not blurting out that something bad happened to her. And mom's actually here and trying to help her. And the daughter prior to this had some normitude within it and functioned in an efficient manner. So, do we want to go with drug use and addiction, or do we want to say this person is in Erickson's identity versus role confusion? So we're going to rule out drug use and addiction and go with the developmental age because she's 12 years old and trying to create an identity and trying to fit in with people in some way, shape, or form. We can't assume drug use or addiction based on the symptomology of what in particular we're looking at. Again, we can't assume anything in knowing that human developmental education will benefit you tensfold. Well, that is how we look at that question in particular. Question 3. Social worker has been meeting with a 26-year-old man for the past 3 months around issues with heroin. The man reports he has been finding therapy helpful, but that still struggles with use. During the most recent session, the man reports he relapsed and feels worthless and like everyone hates him. The social worker has previous experience with relapsing on heroin. What should the social worker do next in this situation? A, assess the man for any suicidal ideations. B, discuss the social worker's experience with the man to validate his feelings. C, seek supervision around the counter transference the social worker is experiencing. D, explore the relapse with the man to better equip him to maintain sobriety in the future. When you have your answer, type the word calm into the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is A. Second place is D. Third is B. Fourth is C. Let's look at it. So a social worker meeting with a 26-year-old man, 3 months. Anytime it gives you a length of time, jump right on it because it'll give us what we're looking at. In the focus here, substance use or heroin use. Man reports he has been finding therapy helpful, but struggling with wanting to use. So having some type of cravings around substance use. The man reports he relapsed and feels worthless and everyone hates him. So there's some type of shame and guilt associated with the relapse. The social worker has previous experience with heroin use or relapsing on heroin themselves. What should the social worker do in this situation? So, application question. Why is it an application, you ask? It's a clinical situation, and we have to navigate and parse through it to understand what is going on in the client's situation. So, assess demand for any suicidal ideations. Assess why, because there's no real actually suicidal issues or anything like that in that particular situation. So, it's not going to be a safety in this particular situation. Discuss the social worker's experience with the man to validate his feelings. Intervene. Why? Because yes, it's validating his feelings, but we're self-disclosing, and we rarely self-disclose our experience because it's not about us. It's about the client's situation. Seek supervision around the countertransference the social worker is experiencing. Intervene. Why? Because there's no issues of countertransference. It just simply stated that the social worker has prior experiences. It doesn't say it's trying to interweave and interfering with the person's practice in any way, shape, or form. So that's not how we would look at the question. Explore the relapse with the man to better equip him to maintain sobriety in the future. That's going to be feelings because it's going to be getting his view of his current situation and what led up to the relapse and what type of feelings and reservations he has. So, quick review: 26-year-old man, 3 months with the social worker, heroin use. He's struggling with wanting to use. He's finding the therapy helpful. He relapsed. He's feeling worthless, feels like everyone hates him, and the social worker has previous substance use history themselves. So we're automatically going to rule out supervision because there is no concerns or struggles that the social workers currently have in around this. Yes, they have similar substance use histories, but the social worker is not saying that it's interfering with how they conduct themselves in any way, shape, or form. We're not going to self-disclose in this situation because us saying like, yeah, I've relapsed on heroin and have prior drug use history, it's not going to help the man in this situation. It's not going to be like, hey, yeah, I felt crappy about myself and like everyone's hated me before. You're not alone, because it's not about us. It's about them, and they're saying they're feeling worthless and like everyone hates them. And There's no suicidal ideations. Yes, it says that he's feeling worthless, but every time someone says they feel worthless doesn't mean they're trying to kill themselves. And it doesn't mean he's depressed. And if anything, feeling like everyone hates him is more or less anxiety because he's worried about what people are going to say and accept or not accept him now in his current situation. So from this, we need to explore the man's situation, his view of everything, and we could better understand if there are some suicidal tendencies or anything like that. But we're not instantly going to jump through and be like, hey, do you want to kill yourself? We're going to say, hey, man, what does it look like for your situation? And how can we better help you in the future? So D would be the correct answer. So that is how you would look at that question in particular. Question 4. A social worker at a family agency has completed an intake assessment with a 25-year-old man and his 50-year-old husband. The couple would like to gather information to adopt a child since they do not know where to start. The social worker does not support gay couples adopting children since it has never gone well at her agency in the past. What would be the best thing for the social worker to do in this situation? A, seek supervision to work through her current struggles. B, provide information to the couple to help them adopt a child. C, refer the couple to another therapist that can better assist them. D, provide information to the couple around the difficulties of parenting. When you have your answer, type the word tricky into the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is B and C, equal amount. Second place is A, no one entertained D. So let's look at it. Social worker, family agency, intake assessment, first time meeting them. 25-year-old man, 50-year-old husband are our clients. They want to gather more information to adopt a child since they do not know where to start. So that's the issue. Social worker does not support gay couples adopting children since it's never gone well in the past. Social worker has some types of reservations. What would be the best thing for the social worker to do in this situation? So this is going to be a reasoning question because it's more along the lines of an ethics question and what we actually need to do in a particular clinical situation and coming up with a solution to a problem. So that's our first introduction to a reasoning question. So with that, we have to know our ethics in order to do it. So we're not going to provide information to the couple around the difficulties of parenting because we're not trying to talk them out of adopting or it's from not being parents. That'd be bad moves, bad vibes. That's us letting our biases enter in. So with that, we're not going to seek supervision around this issue because this isn't something we can supervise out. We only supervise out clinical issues. This is a personal problem and personal issue for the social worker. So quick review within this. Family agency, intake, first time meeting, 25-year-old, 50-year-old. They want info. We don't feel like we can work with them because we don't support gay couples, adopting children. So we're not going to refer out because, again, this is a personal issue within us. And we have to leave our biases and personal issues at the door. We can't say, oh, just because based on a particular identifying characteristic about someone, we can't help them. That's bad moves, bad vibes. We're a social worker. They come to us for help. We need to help them. Put your biases and bigotry to the side and get the job done. So for that particular answer, we're going to provide them the information because that's what they came there for. And they told us why they need that situation. They said, I need the information because I don't know where to start. So we don't need further information of what we need in their situation. So we need to get the job done and stop trying to dictate and determine who we can help based on our own particular issues. You leave your biases, you leave your values, you leave your own ethics at the door, and you're a social worker under the code of ethics that says we do not discriminate based on any identifying information to the person. So that is how you look at that question in particular. Question 5. A social worker at an outpatient clinic has been facilitating a trauma-based group for the past 3 months. The social worker has reviewed the rules and regulations of group facilitation to the members to inform them of the social worker's duties. During the most recent session, a group member reports that she was the abuser in her relationship and that she killed her partner during an argument. What should the social worker do first in this situation? A, inform the woman she can discuss that the social worker after group. B, allow for the group members to process the woman's disclosure and provide support to her. C, inform the woman that discussing that in group is inappropriate and reiterate the rules and regulations of group. D, gather more information from the woman to allow for the social worker to contact the appropriate authorities. And when you have your answer, type the word best in the chat. Opening the polls. 30 more seconds. Slapping the polls shut. The majority think it is B. Second place is D. Third is A. Fourth place is C. Let's peel it back. Social worker, outpatient clinic, facilitating a trauma-based group, and we are looking at 3 months. So we've been doing this for a decent amount of time. The social workers review the rules and regulations of facilitation to the members to inform them of the social worker's duty. So we're all on the same page of what confidentiality and all of the reporting rules are. So a group member reports that she was the abuser in her relationship and she killed her partner. What should the social worker do first in this situation? And this one's also going to be a reasoning question because this is kind of an ethical consideration. Somebody pops up in the spot, tells us they've killed someone in the middle of a group. So let's get a quick review in. We're in an outpatient clinic. It's a trauma-based group. 3 months we've been doing it. We've viewed the confidentiality rules and what our regulations are on reporting. A group member says, I was the abuser rather than the person being abused, and I killed someone. So we're not going to immediately tell her, like, that's inappropriate. This is why. Because we don't want to shut this woman down because this information is pretty pertinent. And keep in mind, it's a trauma-based group. So we can talk about traumatic things in here and also be able to get support around our particular situation. But we're also not going to gather information to contact the appropriate authorities because we're in the middle of a group. We're not going to ask particular details and have this one person be the focus of the group because not one person is the absolute focus, and our immediate action is not going to jump to the police. This is not something we need to discuss in front of everybody in automatic detail. This could be automatically triggering to a whole bunch of people because most times people in trauma groups are the person that was being abused. And if someone's illicitly talking about a trauma story to everybody, it could throw them into a huge tirade and be negative on their particular situation. So do we want to have her talk to us after group about the situation, or do we want the group members to help her process that? And again, we're not going to have them process this particular situation because it could be automatically be triggering to these people. And we don't want to hear about criminal activity within group. And let's say this person is psychotic. We're not going to have this person tell a psychotic story in the middle of group. So we need to tell her, yes, this is a trauma-based group, but how about I talk to you after the group? Keep your confidentiality as well as keep the focus on this group about recovery rather than re-traumatizing and describing stories that automatically could be very detrimental to the people in the group. So again, there are huge factors when it's in the groups. If it's about substance use, if it's about legal, if it's about trauma, we have the person talk to us individually to make sure what they're about to share in the group is automatically going to be able to be something that is needing to be shared. So that's how we look at that question in particular. Question 6. Social worker at a community mental health agency has been working with a 30-year-old female for the past 4 months. The social worker and woman have been working on ways to improve her depression by getting more active in the community. The social worker sees the woman at the book club that she's been attending at the local library for years. The woman walks up to the social worker and says, I'm so happy I know someone here because I was so nervous to attend. What would be the best thing for the social worker to do to treat the woman? A, continue to attend the book club since the woman is comfortable with the social worker being there. B, drop out of the book club and find another one in the area to avoid any issues. C, validate the woman's accomplishments and ask her to attend a different book club to avoid any issues arising. D, refer the woman to another social worker to avoid any issues. And when you have your answer, type the word learn in the chat. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is B. Second place is D. Close third is A. Fourth place is C. So let's look at it. Social worker, community mental health agency, working with a 30-year-old female, past 4 months. Social worker and woman have been working ways to improve depression, and the goal is getting her more active in the community. Social worker sees the woman at the book club she's been attending for years. So she's been doing this for a while. The woman walks up to the social worker and says, I'm so happy I know someone here. I was so nervous to attend. This is going to be a reasoning question because it's, again, going to be an ethical consideration that we have to respond to in an effective and efficient manner. So we'd have to know what are the regulations on dual relationships as well as conflicts of interest. So quick review, community mental health agency, 30-year-old female. We've been doing this for 4 months. She's been depressed. She wants to get more active in the community. And We see her at the book club that we've been for years. She's excited to see us. So, A, continue to attend the book club since the woman is comfortable with the social worker being there. We're going to automatically rule this out because, yeah, she's comfortable with us being there, but we're not going to also read a book and get close to a client because we do not need a dual relationship here. Why is that a dual relationship? Because we're occupying the therapist hat, but we're also kind of in a friend role at the library talking about books. And when you talk about books, you're typically going to relate them to your lives, and they're going to get to know more about your life than they probably should. We're not going to automatically drop out of the book club because we've been going there for years. We're not going to change our basis of life based on one client that we've had for 4 months. Do not sacrifice your life based on that. We're not going to drop out of the book club, find a different one, and ruin all of the relationships we've had from going there. We've been doing this for years, guys. So do we want to validate our concerns and ask her to go to a different one, or do we want to automatically refer her out? So we're going to rule out C because, yes, we're validating, but she was also depressed and it was hard for her to come to the group. Why shut her down and tell her to go to another one when we can refer her out because her goal was to get more active in the community and she has done so. So we can discharge her out of our services, refer her to someone else so that way she can, one, continue to build on her treatment goal as well as not get shut down for something that she tried doing. So whenever there's a possibility of a dual relationship, we are going to refer the person out. We're not going to tell them to get the heck out of there. We're not going to tell ourselves to get the heck out of there. And we're not going to put ourselves in a dual relationship situation. Whenever there's a possibility of a dual relationship, we have to refer the person out so that way there's no boundary issues in that situation because we're not going to tell the client to change their lives. We're not going to change our lives. And we can refer them out, be the same book club as this lady because she's no longer a client. And in a book club, you're not going to be meeting at each other's houses and becoming buddy-buddy. Because in our ethics, whenever there's a possibility of a dual relationship, we have to bear the burden and eliminate that, and we'd ship them to somebody else. That's how we could look at that question in particular. Question 7. A clinical supervisor at an outpatient clinic has been struggling with retaining social workers for more than 1 month after hiring them. The social worker has tried reaching out to previous employees but has failed to reach out to them. The social worker would like to improve the clinic but is unsure where to start. What should the social worker do next? A, continue to attempt to engage the previous employees to gain their perspective. B, reach out to the clinical supervisors at the other agencies to find out what has worked for them. C, explore incentive programs that she can implement at the clinic. D, reduce the current therapist caseloads to allow for the job to become less stressful. When you have your answer, type the words, stop second guessing. Opening the polls. 25 more seconds. All right, slap on the poll is shut. The majority think it is B. Second place is C. Third is A and D. Let's peel this back. So we are a clinical supervisor and we are at an outpatient clinic who has been struggling with retaining social workers for more than 1 month after hiring them. They're there for a month and then they're piecing out. Social worker has tried reaching out to previous employees. They have failed to do so. They're like, heck with you. Social worker would like to improve the clinic, unsure where to start. So this one is going to be more of a recall question because you have to know the program development and a program evaluation type information in this question to know how to answer it. So clear cut way is having to know the information because if you don't, it's going to be kind of hard to answer it. But let's break this bad cat down. We're a clinical supervisor, outpatient clinic. We're struggling to keep employees. We're reaching out to previous ones. They said I'm not answering and we'd like to improve, but don't know what to do. So we're going to automatically rule D out because those are talking about current therapist, and that's going to do nothing to help retain new therapists. Keep in mind, current therapists are important to us, but that's not impacting us being able to maintain future because that is who we're trying to appease as future clinicians. We're not going to continue to engage previous employees. We tried. We're not going to work harder than they are. And if they're not getting back to us, they're not going to get back to us. So we need to move on to the next stage. So does that mean we need to explore incentive programs that we can implement at the clinic? Or do we want to tap into other people that have done this and have ideas and that they're working efficiently with? So we're going to rule out looking at incentive programs because in program development, we need to understand what is currently being going on with other people so that way we don't reinvent the wheel. We've already tried reaching out to the people that we could get the information from. We've done that step. If we had not reached out to previous employees and that was the answer, that would be our first step. But we've already done that. So then we have to move to the next and have to get the information from other people, what they're doing and what's worked for them. So that way we don't reinvent the wheel and try to drive ourselves crazy, mix and matching. So that is how you would look at that question in particular. Question 8. Social worker at a family agency has been working with a 35-year-old female for the past year to address her heroin use. Throughout treatment, the woman has had multiple CPS cases that have not been substantiated yet have caused her to experience periods of low mood and anxiety. The woman denies any relapses and that she just wants to be a good mother to her children. The social worker receives a court order for the woman's records regarding the custody of her children. The social worker contacts the woman about the request. What should the social worker do next? A. Assert privilege on behalf of the woman. B. Seek supervision around the request and understand the agency's policy. C. Advocate on behalf of the woman and keep her records confidential. D. Release the part of the records that can make the woman look good for the case. And when you have your answer, type the word happy into the chat. Opening the polls. Thirty more seconds. Slapping the poll shut. The majority think it is C. Second place is B. Third is A. No one touched D. Let's look at it. Social worker, family agency, working with a 35-year-old female, and we're looking at 1 year, and the issue was heroin use. The woman has multiple CPS cases, but they were never substantiated. But low mood, anxiety were a result. She denies any relapses, and she is focused for her children. So the key thing, social worker receives a court order for the woman's records regarding custody. Key emphasis, court order, meaning it's an order and we have to follow it. And we already contacted the person. So that's another key detail. So this one is going to be reasoning question because we are looking at our ethics. But if we want to get semantical, it could also be a recall because we have to know the information based on subpoenas and court orders. So depending on how you want to identify it, you're not wrong either way. But if you try applying the acronym here, you are going to be a sad panda. So we have to know the process. So quick review, family agency, 35-year-old female. We've been doing this 1 year. She came for heroin use. CPS has been involved. No cases were substantiated. She's having low mood and anxiety because of it. No relapses. She's motivated. We got a court order and we contacted her. So we've already done one step. So that automatically shaves it off. So we're not going to assert privilege because when it's a court order, it's an order and we have to listen to it. Subpoenas, on the other hand, it involves peon. So we don't listen to peons. So we can assert privilege on that because that's from a lawyer. This is from a judge. So a court order is something that we cannot ignore. So we're not going to release part of the records because that's not going to be truthful. We would disclose the least amount of information we could to make it a case, but we're not going to admit any information that could potentially put ourselves at liability for not disclosing all of the information. So are we going to advocate on behalf of the woman to keep her records confidential immediately, or are we going to seek supervision around the request? So at this time, we're not going to advocate because we need to understand our agency's policies on behalf of advocating for the client. And is there someone at our agency that could advocate in our place, or what is agency policy when disclosing and sharing records? Is it even involving us disclosing the records, or does it involve our administrative staff doing so? We have to know the process. We have to be conditioned around this, and this is something that we have to respect. We can't assert privilege. We can't advocate yet because we don't know the process, and we do not only disclose half the records. But that is how we look at that question in particular. Question 9. A social worker in a psychiatric hospital is meeting with a 45-year-old female after she tried to kill her roommate 5 days ago. The woman reports her roommate has been abusing her and her mother for the past 6 months and that she just got fed up with it. The woman denied ever having any previous hospitalizations and that this is the first time. The woman reported she would like to get home to protect her mother. What should the social worker do next in this situation? A, contact the appropriate authorities to ensure the client's mother is safe. B, continue to explore the woman's comments around the abuse. C, explore the woman's mental status and function. D, commend the woman for standing up for herself and her mother. When you have your answer, type one thing that you've learned in this session today. Opening the polls. Thirty more seconds. Slapping the polls shut. The majority think it is A. Second place is B and C. No one touched D. Let's look at it. Social worker, psychiatric hospital, 45-year-old female. She tried to kill her roommate, and this was 5 days ago. She reports her roommate has been abusing her and her mother for the past 6 months, and she just got fed up with everything. So, 6 months this has been going on. The woman denied ever being hospitalized, and this is her absolute first visit. Welcome. The woman reported she would like to get home, protect her mother. So this one's going to be an application question because it's a client scenario and we have to apply what we know and parse through the different layers. There's a lot of things going on. So contact the appropriate authorities to ensure the client's mother is safe. So we can have a safety or we can have an intervene option. Continue to explore the woman's comments around the abuse. Assess. Explore the woman's mental status and functioning. Assess. And commend the woman for standing up. Intervene. Why? Because we are commending her for something in an action to do it. Social worker, psychiatric hospital. So that's important. We are in a psych unit. 45-year-old female. She tried killing her roommate. This was 5 days ago. And she says that her roommate has been abusing her and her mom 6 months, and she's never done this before. So contact the appropriate authorities. We're going to make that intervene. This was 5 days ago. So if her mom's in danger, she's probably already dead. So safe to rule that out. Plus, if someone's going to a psychiatric hospital, likely the cops are the one that brought them there, either through EMS or themselves. So if the mom was in danger, the cops weren't just going to like hit the gas pedal and leave the house. They would have investigated further, and we're in a psych hospital. And we're not going to commend the woman for trying to kill someone. That's like us congratulating Ted Bundy for what he has done. Bad moves, bad vibes, and it feeds a dragon. So, do we want to understand her situation, or do we want to check her mental status to make sure what she's saying is pretty accurate? So we're not going to investigate further into that. We need to make sure this woman is in sound mind, body of reason before being able to do this, because we need to make sure she is able to function and relay information prior to being able to get further into this. So that is how we would get into that question in particular. These are difficult questions, guys. So keep focused and you'll be able to get the correct answer. So the 10th and final question, social worker in a private practice is completing an intake assessment with a 24-year-old male for concerns of impulsivity. The man reports he finds it difficult to open up to people and often will cut them off before they get close to him. The social worker inquires about past trauma, and the man reports being abused my entire life. The man reports that he copes with his past trauma by drowning himself in work and avoiding any instances of pleasure because he does not feel he is worthy of any. What should the social worker consider when working with the man? A, the treatment will have to be short-term focused due to the man's inability to trust people for long periods. B, the man practices asceticism and setting frequent goals will be helpful for him. C, processing the man's trauma will allow for him to improve all of the issues he is experiencing. D, allowing for the man to guide his treatment will lead to the best possible outcomes. And when you have your answer, type one thing that you're grateful for at this given moment. Opening the polls. Thirty more seconds. Closing the polls down. First place is A. Second place is C. Third place is B. Fourth place is A. Let's peel it back. Social worker, private practice, intake assessment. We're meeting with 24-year-old male. Concerns of impulsivity. The man reports he finds it difficult to open up to people and will cut them off before they get closer to him. Social worker inquires about past trauma. He's been doing this his entire life. He has had it. The man reports he copes with it by drowning himself and derives himself of pleasure because he does not think he is worthy of any. What should the social worker consider when working with the man? And this is going to be a recall question because we have to know particular concepts to know how to peel it back. So, quick review. Social worker, private practice, intake assessment, 24-year-old male, and concerns of impulsivity. He's cutting people off before they get close to him. He's experienced trauma, and he's coping with drowning himself and deriving pleasure. If you ask me, that sounds like asceticism, which is the defense mechanism established by Freud. So let's keep that in mind as we look at the answers. So that is why it's a recall question, because you need to know what asceticism is and how it can impact services. So the treatment will be short-term focused due to the man's inability to trust people. We can't assume that it's going to be short-term, that he's not going to establish a relationship with us, because he came in for an intake and he's trying to work on his traumas. So we can't assume it's about to be short-term. And we can't say, how about you process your trauma? Because this is going to how it's going to unlock what you need to get us going. Because we can't assume he's going to be willing to want to work on the trauma. He's here for impulsivity. He's not here for trauma. So he's trying to work on improving himself in the impulsive realm. He's not trying to work through his trauma at this given moment. Therefore, are we going to allow for him to guide the services, or are we going to take the wheel and utilize his asceticistic manners and set frequent goals? So we are going to rule out allowing him to guide it. And we need to keep in mind he's goal-oriented. So if we allow for him to have frequent goals, one, he's going to be more engaged in services. And two, he does not have to stay within the connection with us. He's going to be shooting for goals for himself, which is going to keep them focused, which is going to keep them engaged. And that is where we have to know our Freudian theory of defense mechanism. So that is how we would look at that question in particular.